Good afternoon, everyone. Today we will discuss about gallbladder. We have already completed liver. Normal gallbladder, it is a pear-shaped organ. It is 9 centimeter in size. Its capacity is 50 ml. It consists of a fundus, a body, a neck. The neck tapers into a cystic duct. The cystic duct and the common hepatic duct together forms the common bile duct. The common bile duct opens in the second part of the duodenum. Sometimes this common bile duct, it is joined with the pancreatic duct to form ampulla of Vater. Then it joins the duodenum after forming the ampulla of Vater. Normal histology of gallbladder. The gallbladder consists of mucosa, then is the smooth muscle layer, then is the perimuscular layer, then is the serosal layer. There is no submucosal or no muscularis mucosal layer. So the first layer is the mucosal layer, which consists of tall columnar cell. Then is the smooth muscle layer. Here 3 types of muscles can be seen. Inner is the longitudinal muscle, middle is the oblique muscle, and outer is the circular muscle. Then is the perimuscular layer. It consists of fibrous connective tissue. Then the outside is the serosal layer. This is the normal structure of the gallbladder. The right side shows the mucosal layer and the left side is the muscular layer. Gallbladder consists of bile. The constituent of bile is 67%. The majority is formed by the cholates. They can be chenodeoxycholate, deoxycholate, lithocholates or urodeoxycholates. So the major constituents is the cholates. Then 22% is formed by the phospholipid. 4% is cholesterol, 0.5% is bilirubin, and the rest is protein. So this is the major constituent of the bile, and this bile is stored in the gallbladder. Now we will discuss about gallstone. Gallstone is stone in the gallbladder. This is also called cholelithiasis. Cholelithiasis, this affects 10 to 20% of the adult population worldwide. Worldwide, 30 million population suffers from gallstone. There is 1 million new cases every year. More than 80% of the gallstone or cholelithiasis is silent. There is no symptom. It mainly affects female who are above 40, fertile, and who is fat. Fat, 40, fertile female. So these are the 4 Fs. Fat, 40, fertile female. Cholelithiasis affects mainly female above the age of 40 who have given multiple childbirth and who is obese, who is fat. Now, gallstone cholelithiasis is of 3 types of stones can be seen. They can be pure stone, mixed stone, or combined stone. Pure stone can be pure cholesterol stone or pure pigment stone, that is mainly bilirubin stone, or pure calcium carbonate stone. Then there can be mixed stone or there can be combined stone. Now prevalence and risk factors of cholelithiasis. First we will discuss prevalence and risk factor of cholesterol stone. Cholesterol stone, it is mainly seen in the Native American, 75% of it is seen in Native American. Pigment stone is rare in Native American. Cholesterol stone is present in industrialized country. In developing country, it is rare. It is in less than 40 years of age, it is less than 5% prevalence. In more than 80 years of age, it is more than 30% prevalence. In white women above the age of 40, 50% of the white women above the age of 40 suffers from cholelithiasis. Environmental factors also affect the formation of cholesterol stone, such as oral contraceptives, pregnancy, chlorfibrate. All these causes increase in hydroxymethyl glutaryl coenzyme A reductase. So this HMP-CoA reductase is an enzyme needed for fat cholesterol metabolism. So this enzyme, when it increases, then production of cholesterol increases. So this enzyme increases due to these oral contraceptive, pregnancy or chlorfibrate. They causes increase of hydroxymethyl glutaryl coenzyme A reductase. So that can lead to increase in cholesterol in the bile. That can lead to formation of cholesterol stone. Obesity and rapid weight loss can also lead to increased cholesterol in the bile. Now some acquired disorder such as gallbladder stasis, which can be either neurogenic or humoral, can also lead to cholesterol stone formation. Some hereditary factors such as hyperlipidemia can also lead to formation of cholesterol stone. Now causes of formation of pigment stone. Pigment stone, it can be either black in color or it can be brown in color. It is mainly made up of unconjugated bilirubin. So hemolytic disease, in hemolytic disease this prevalence of pigment stone increases. It can also occur in ileal dysfunction, in bacterial contamination of biliary tree and in northwestern population. Now cholesterol stone, pathogenesis of formation of cholesterol stone. Cholesterol stone can be formed due to supersaturation of the bile with cholesterol. Normally cholesterol is insoluble in water. In bile it is soluble due to the presence of lecithin and bile salt. They keep the cholesterol in a soluble form in the bile. When the cholesterol formation increases and the lecithin amount and the bile acid amount is constant, then the cholesterol bile is said to be supersaturated with cholesterol. Then cholesterol starts to deposit. Cholesterol nucleation occurs. This nucleation can occur on any calcium carbonate particle or it can occur on mucus secretion also. Then cholesterol nucleation can occur also due to mobility of the gallbladder. When the gallbladder becomes less motile and not able to secrete out the bile present in it, there is stasis of bile is occurring in the gallbladder, then also cholesterol stone gets formed. The mucus hypersecretion can also lead to trapping of the crystal and agglomeration of the cholesterol. Then cholesterol stone, it is normally in cholesterol stone 50 to 100% is cholesterol. The stone is a pale yellow in color. It is round to oval in shape, mostly single stone. There can be discoloration due to presence of some amount of calcium salt or some amount of bilirubin, but pure cholesterol stone is yellowish in color. It can be multifaceted and it is radiolucent. That means in X-ray light passes through it. It is radiolucent. But if calcium content increases, then it becomes radio opaque. So this is the pigment stone. It can be, we have already discussed, it can be either black or it can be brown. Black pigment stone occurs in uninfected cases, and when the stone becomes infected, then it becomes brown in color. So black is due to oxidized polymers of calcium salt of unconjugated bilirubin, calcium carbonate, calcium phosphate, mucin glycoprotein, and this pigment stone is fragile. It easily breaks down. Brown occurs in infected bile. It is composed of calcium salt, cholesterol plus calcium salt of palmitate and stearate. And in 50 to 75% cases, it is radio opaque. Mixed gallstone, 80% of the all gallstone are mixed type. Maximum gallstone is of mixed type of gallstone, composed of all the things: cholesterol, calcium, bile pigment, and fatty acid. Mixed gallstone is present in sand grain form or particles of up to 1 centimeter in size. On cutting this stone, alternate areas of pale and dark areas can be seen. Pale areas are mainly made up of cholesterol, dark areas of the due to bile pigment. So this is the mixed gallstone, which is the maximum stone found in gallbladder. Then combined gallstone. Combined gallstone has a pure gallstone nucleus. Nucleus is made up of pure stone. That is, either it can be pure cholesterol or pure bile pigment, or it can be pure calcium carbonate. And outer is made of mixed, which can be made up of cholesterol, calcium carbonate, bile pigment, fatty acid. Outer is mixed and the center is pure. This type is known as combined gallstone. This combined gallstone is single, solitary, and it is a large gallstone. This is a picture showing mixed gallstone. Mixed gallstone is also known as composite gallstone. Now, clinical features of cholelithiasis. 70 to 80% of the cases, it is asymptomatic. There is no pain, nothing. The patient is not able to detect that he has got gallstone. In 1 to 3% of the cases, symptoms may occur. Symptoms can be biliary pain, which can be a constant biliary pain or colic type of biliary pain, occasional pain. Complications of cholelithiasis, there can be empyema, perforation, fistula formation, cholangitis, obstructive cholestasis, and pancreatitis. In unobstructed cases, there can be uninflamed gallbladder with mucocele or hydrops. Mucocele means when the gallbladder is obstructed, then what happens? Increased mucus secretion occurs. This mucus secretion fills the gallbladder with a clear fluid-like structure. This is known as mucocele or hydrops. This is a picture showing sites where gallstone is most common gallstones are formed. A is in the gallbladder, B is in the hepatic duct, C is in the cystic duct, D is in the pancreatic duct, E is in the duodenum. Now there is a term cholesterolosis. Cholesterolosis is called when cholesterol is increased in the gallbladder and cholesterol forms esters. Cholesterol esters are formed. Then these cholesterol esters are engulfed by the macrophages present in the lamina propria of the gallbladder, and they give a strawberry appearance to the, when this diffusely occurs in the whole gallbladder, gives a strawberry appearance to the gallbladder, and it is known as strawberry gallbladder or cholesterolosis. So cholesterol esterification occurs in the mucosa and engulfed by the macrophages. Then these macrophages are called foam cells, and this is called strawberry gallbladder. Now we will discuss another disease of the gallbladder, that is cholecystitis. Itis means inflammation. So we will discuss about the inflammation of the gallbladder. Cholecystitis can be either acute or it can be chronic, or it can be acute on chronic. The patient is already suffering from chronic cholecystitis. On top of it, acute symptoms develop. So it can be acute, chronic, or acute superimposed on chronic. Acute is of 3 types: calculus, acalculus, or emphysematous. Chronic is also of 3 types: calculus, acalculus, or xanthrogranulomatous. Now, acute cholecystitis, it is defined as acute biliary pain with fever, right hypochondrial tenderness and guarding with their persistence for more than 24 hours. So there is biliary pain with fever, and in the right hypochondrium there is tenderness and guarding, and this continues for more than 24 hours. Then it is called acute cholecystitis. This is an emergency situation. This cholecystitis can be either due to stone, calculus, or can be without stone, acalculous. Calculus stone is present in 90% of cases of acute cholecystitis, and this stone is mainly blocks the neck of the gallbladder. And in acalculous cholecystitis, this occurs in acalculous cholecystitis occurs in severely ill patient, in post-operative cases, in severe trauma, in severe burns, in multi-system organ failure, in sepsis, in prolonged IV hyperalimentation, and in postpartum state after childbirth. So these are the conditions in which acalculous cholecystitis occur. Calculous cholecystitis is more common. In 90% cases there is calculous cholecystitis, and in 10% cases only there is acalculous cholecystitis. Now, pathogenesis of cholecystitis. Cholecystitis means inflammation of the gallbladder. So due to stone, what happens? There is irritation and inflammation. So due to this irritation and inflammation, lecithin, which is present in the bile, gets converted into lysolecithin by mucosal phospholipase. Due to irritation, the mucosa of the gallbladder secretes phospholipase, and this phospholipase converts the lecithin into lysolecithin. Now this lysolecithin, it disrupts the glycoprotein mucosal layer. The mucosa of the gallbladder has a layer of glycoprotein to protect it, and this lysolecithin disrupts this layer, and then the bile salt that can act directly on the mucosa, giving a direct detergent action and causing damage to the mucosa. So what happens? Lecithin is not damaging to the mucosal layer, but lecithin, when it gets converted into lysolecithin by the action of the phospholipase, the lysolecithin then damages the glycoprotein, exposes the mucosa. Now the mucosa, bile salts acts on the mucosa and damages the mucosa, and so this leads to cholecystitis. Other factors that also aggravates this condition is gallbladder dysmotility, decreased mucosal blood flow, and bacterial contamination. That means on top of this damage to the mucosal layer, gallbladder dysmotility can also add up to the damage. Decreased mucosal blood flow and bacterial contamination also add up to the damage to the mucosa. Now, damage to the mucosa in other condition where there is no stone, that is acute acalculous cholecystitis. Damage to the mucosa can be due to direct ischemia. When there is less blood flow, then the mucosa is not able to get enough blood and it gets damaged. So that can be direct ischemia, dehydration, multiple blood transfusion that leads to pigment load. There can be gallbladder stasis. When there is gallbladder stasis, the bile become viscous, and this viscous bile obstruct the cystic duct. There can be bacterial contamination. Bacteria also converts lecithin to lysolecithin, and then again this lysolecithin will damage the mucosa. So these are the things that damage the mucosa in absence of stone. So acute acalculous cholecystitis can be due to these factors. Now, in acute cholecystitis, grossly, there can be empyema of the gallbladder. Gallbladder becomes a bag full of pus. Empyema means bag full of pus. There can be gangrenous cholecystitis. There can be gangrenous necrosis. There can be perforation, or there can be primary bacterial infection. Bacteria that can infect in a cholecystic condition are the Salmonella typhi, Staphylococci. There can be emphysematous cholecystitis. Emphysematous cholecystitis means there can be air spaces in the mucosal layer. So this can be due to infection by Clostridia and coliform bacteria. This occurs mainly in the diabetes. Then clinical features of acute calculus cholecystitis. In acute calculus cholecystitis, it can appear suddenly. It is a surgical emergency. There is progressive right upper quadrant pain, and or there can be epigastric pain also, with fever, anorexia, tachycardia, diaphoresis, nausea and vomiting. There can be hyperbilirubinemia because due to common bile duct obstruction by the stone. That in 25% cases the symptoms goes on increasing, and in some cases the patient recovers, but recurrence again occur. Again the patient gets attack of acute cholecystitis. Then clinical features of acute acalculous cholecystitis, where there is no stone. Here the onset is insidious, slow onset. Diagnosis is done by high index of suspicion. The clinician thinks that it can be an attack of cholecystitis, then only diagnosis is done on that direction. And here early diagnosis is crucial because we have to treat the cause that is leading to this acute acalculous cholecystitis. So this was about acute cholecystitis, which now we will discuss about chronic cholecystitis. Chronic cholecystitis may be a sequel to bouts of acute cholecystitis. Many acute cholecystitis will ultimately lead to chronic cholecystitis, or in some cases there is apparent absence of acute attack. So there is no acute attack, but suddenly the patient develops this type of cholecystitis, then it is called chronic cholecystitis. 90% cases there is stone present, is associated with cholelithiasis. In 1/3 cases the bile is infected with E. coli or enterococci. Now the morphological features of chronic cholecystitis. This morphological feature can be variable. There can be subserosal fibrosis with adhesion. There can be thickened grey white opaque wall. Stone is usually seen. Xanthogranulomatous cholecystitis can be seen, or there can be hydrops of gallbladder. Xanthogranulomatous means macrophages have engulfed the cholesterol and granulomas have occurred. So this is known as xanthogranulomatous cholecystitis. And there can be hydrops of the gallbladder. We have already discussed hydrops means mucocele of the gallbladder. Mucin secretion has increased in the gallbladder. So these can be the features of chronic cholecystitis. Clinical features: there can be recurrent attack of the right upper quadrant or epigastric pain, which can be either steady pain or there can be colicky pain. There can be nausea and vomiting, and there is intolerance to fatty food. There are some variants of chronic cholecystitis. These are cholecystitis glandularis. Here mucosal fold, the gallbladder mucosal fold, they go deep inside and the fold fuses together. So the crypts of the epithelium gets buried in the gallbladder wall, giving it a glandular appearance. There can be porcelain gallbladder. Gallbladder wall is calcified, gives a look of an eggshell. Or there can be acute on chronic cholecystitis. Acute changes occur on top of the chronic cholecystitis. Now the complications of chronic cholecystitis. there can be bacterial superinfection with cholangitis or sepsis. The gallbladder perforation can occur and local abscess can be formed. Gallbladder may rupture with diffuse peritonitis, or there can be biliary enteric fistula. The fistula can be formed between the gallbladder and the intestine, or there can be intestinal obstruction. Biliary enteric fistula is more common than intestinal obstruction. There can be aggravation of the pre-existing medical illness. This is a picture showing porcelain gallbladder. Here the gallbladder wall is calcified and gives a eggshell appearance. This is a picture showing Ascough-Rottinski sinus. Ascough-Rottinski sinus is a feature seen in chronic cholecystitis. Here the mucosa goes deep inside the and up to the muscularis layer. We can see in the right side the mucosa has gone deep inside up to the muscularis layer. This type of is known as Ascough-Rottinski sinus. This is also a picture of chronic cholecystitis showing chronic inflammatory cells in the mucosa. Now we will discuss about tumors of the gallbladder. Carcinoma of the gallbladder, it is slightly more common in female. It occurs mainly after the 7th decade. The 5-year survival rate is very poor. Only 1% people survive in 5 years. Gallstone is present in 90% cases. In Asia, parasitic disease may also lead to parasitic disease in liver, and gallbladder can also lead to carcinoma of the gallbladder. The cause of carcinoma of the gallbladder can be due to chronic irritation by the bile acids. So these are the causes of carcinoma of the gallbladder. So mainly in women in the 7th decade, 5-year survival rate is 1%. Gallstone is present in 90% cases. Parasitic disease can also be present, mainly due to irritation of the bile acids. Mainly it is adenocarcinoma. Pattern of growth is either it can be infiltrating growth or exophytic growth. Microscopically, maximum is adenocarcinoma, 5% is squamous cell carcinoma, and less than 1% is poorly differentiated carcinoma. This is a picture showing cholelithiasis with adenocarcinoma of the gallbladder. In the right side, we can see the white stones, gallstones, and in the central part is the adenocarcinoma area. This is a low power view of the adenocarcinoma of the gallbladder. In the left side, we can see the abnormal glands in the gallbladder. Now, the clinical features of adenocarcinoma of the gallbladder are: the preoperative diagnosis is very less, very exceptional. Gallbladder carcinoma is very difficult to diagnose because it has got a slow onset, insidious onset, and it is indistinguishable from cholelithiasis. 90% patient there is cholelithiasis, stone is present, so the stone is diagnosed, but the carcinoma is not able to be diagnosed with the stone. The patient may present with pain, jaundice, anorexia, nausea and vomiting. The gallbladder may be palpable in acute cholecystitis, or in other cases it may not be palpable. It is an incidental finding after cholecystectomy. Due to gallstone, cholecystectomy is done, the gallbladder is removed, and in histopathology, the carcinoma is discovered. So this is called incidental finding. So the gallbladder was removed due to gallstone, and the carcinoma was diagnosed later in histopathology. So carcinoma of the gallbladder is mainly discovered incidentally. Now, carcinoma of the extrahepatic bile duct. It is a uncommon carcinoma. It is painless, progressive, deepening jaundice is seen in this. This occurs in older male. Gallbladder carcinoma was occurring more in female, but extrahepatic bile duct carcinoma occurs mainly in male. This occurs in high risk patient who are suffering from, who have got liver fluke or have primary sclerosing cholangitis or inflammatory bowel disease or choledochal cyst. Here adenocarcinoma is most common and survival is very poor, 6 to 18 months only the patient can survive. So we have discussed about the carcinoma of the gallbladder. So this completes the gallbladder. So the extrahepatic bile duct carcinoma, this occurs mainly in the male. The patient may have liver fluke, primary sclerosing cholangitis, inflammatory bowel disease or choledochal cyst. Mainly adenocarcinoma occurs here and survival is 6 to 18 months. Thank you. Till we meet again in the next class.